if anyone can take away a message from the University of Michigan VBIT Center, it's this one. So they're talking to economists. I'm always nervous about talking about supply and demand, but I find it very interesting as a student of the U.S. healthcare system now for approaching 3 decades, which makes me a little nervous about that ultimately there are lots of really smart people who are focusing on the supply side. Physicians like myself, the great clinical delivery system that we have, and the alliterative phrase volume to value did not come from value-based insurance design. It actually came from those people who understood that fee-for-service is no longer sustainable and we need to make a change. And although there's somewhat of a political element to this, as we see post-election 2016, there is an enormous multi-stakeholder, bipartisan approach to the fact that we should not abandon any movement away from fee-for-service to some type of alternative payment system. And I'd like to think that the provider side changes from volume to value are actually moving in the correct direction. And because the audiences I speak to, Dennis, as you know, are not as sophisticated as the people watching this, I refer to supply side initiatives as peanut butter, which you'll understand in a minute. So the supply side, our peanut butter, has gone beyond talking the talk. They are literally walking the walk imperfectly, as you mentioned in your comments earlier, away from fee-for-service to some quality-driven, hopefully patient-centered, outcome-driven payment reform. So you have the supply side of peanut butter going in the right direction. The other side of this equation, which I believe has, for the most part, been left out, and you agree that provider-based initiatives are more important, more sophisticated, and are deserving of the effort and resources. But on the other side of this equation are my patients, right? Are the people that I see driving behind you in State College. And you would like to think that as providers are being asked to behave in a more quality-driven, efficient way, that our patients and the American people would be asked to align with those movements. And instead, we have seen a rapid growth and now a predicted much more faster growth of high-deductible health plans. And high-deductible health plans, as you know, are very blunt instruments that require people to pay 100% of the service out of pocket until the deductible is met. Except for those very few primary preventive services that we talked about earlier that are covered, at least for now, under law, under the ACA, any service that's used to treat an existing illness, injury, or condition, which is 98% of the spend in Medicare and 70% of the spend in commercial plans, those services cannot, in health savings now high-deductible health plans, the priority in healthcare reform of the Trump administration and Speaker Ryan's Better Way Forward program, those HSA high-deductible health plans cannot cover HIV drugs, hemoglobin A1Cs, physical therapy after hip replacement, all those things that, Dennis, you and your colleagues in the quality metric world have told me that I should do more of. So here you see providers moving from volume to value based on evidence. The American people are being either electively or in some situations have no choice to enroll in these health plans that make it harder for them to do the things that their doctors are begging them to do, and now more importantly, the things that their doctors are being benchmarked and paid bonuses for. So the only way we move forward is to make sure that our providers and our patients are aligned around evidence and quality. And I like to use the metaphor of peanut butter and jelly, because if you close your eyes and you think the first time that your mother or father, grandmother or sister put peanut butter and jelly together, it is my best example of the sum being greater than the individual parts. That if we could come to a system where the evidence is strong of individual and population health production, providers and patients, now it is easy for them to do those things, as opposed to now where it might be hard, at least for our patients to do those things, we could get to the triple aim better and faster. And while I applaud the private sector, the Obama administration, academics like yourself for moving these payment reform initiatives forward, I am very fearful that the jelly side, the consumer engagement side, under a non-nuanced high-deductible health plan will only make this situation worse, which is why I will say at least December of 2016, our top initiative at the VBIT Center for 17 is to continue to advance a 10-year advocacy program, the Internal Revenue Service, to allow these high-deductible health plans to have much more flexibility in terms of which services they're able to cover pre-deductible. As we talked about transparency and accountability earlier, I want my patients to be facing high deductibles and high cost sharing on the services that are not going to make them any healthier, right? I want them to health plans to have easy access to those services that make them healthier and those same services for which the providers, their medical homes and their systems are being incented to do more of. And as I like to finish in this political environment we're in, to quote Vice President Dan Quayle, who said, If we don't succeed, then we will fail. And I think that's exactly where we are, which is why we think A, the idea of clinical nuance is absolutely critical to move this forward, and then B, our experience with the ACA, Medicare, and TRICARE, in addition to being motivated by private sector pre-ACA, will spill over and allow these new generations of health savings accounts, which I love from the financial situation, to also encourage as opposed to discouraging individual and population health, as well as economic efficiency.